Hello everyone, I'm Dr. Ishita. Today, I'm going to talk about Approach to Hematuria, a case of NAC OSCE. This video is a part of Starmed Medical Education Program and is just for education purpose only. Here, the clinical scenario is a 44-year-old male who comes to your office with a complaint of hematuria. In exam, you will be provided with specific information about what you will have to do in the next 11 minutes. For example, obtain a focus and relevant history of the presenting complaint. Read the instructions carefully and proceed further. Types of hematuria. We can classify hematuria in broadly two categories, gross hematuria and microscopic hematuria. In gross hematuria, blood is visible in the urine with the naked eyes, whereas we consider microscopic hematuria if there are 3 or more RBCs per high power field in the microscope. Few other terminologies regarding hematuria which will help us in differential diagnosis. First, glomerular hematuria. The specific finding of when glomerulus is the cause of hematuria is the presence of protein in the urine, red cell cast, dysmorphic RBC, and gross hematuria. Second, sometimes dipstick is positive while microscope shows no cell. It shows the presence of myoglobin or hemoglobin in the urine, which we say as myoglobinuria or hemoglobinuria, respectively. Sometimes neither dipstick is positive nor there are cells in the microscope. Still the urine is dark. This is because of the presence of pigments, drug, dyes, etc. Differential diagnosis of hematuria. We broadly classify the cause of hematuria into prerenal, renal, and postrenal. Prerenal causes includes exercise-induced hematuria, drugs like anticoagulants, tumor, thromboembolic disorder, or coagulopathy. Glomerular causes include IgA nephropathy being one of the most common cause of hematuria, glomerulonephritis, thin basement membrane, systemic disease like vasculitis and SLE, and antiglomerular basement membrane antibody disease. Upper urinary tract and walls, renal cell carcinoma, renal stone, pleonephritis, polycystic kidney disease, urethral stricture, sickle cell disease, infections like tuberculosis and sexually transmitted infection, renal trauma, and papillary necrosis. Lower urinary tract cause includes bladder cancer, prostate cancer, BPH being one of the most common cause in male, infections like cystitis, prostatitis, and urethritis, polyps, parasitic infections like schistosomiasis, urethral stricture, and trauma. History taking of the patient presenting with the complaint of hematuria. First of all, introduce yourself to the patient. Confirm name and age of the patient. Read your candidate code to the patient loudly and clearly. Focused history. Ask patient regarding following question. When did the bleeding started? Are there any provoking factors because of which the bleeding started, like stone, urinary tract infections? Important question to ask is the blood visible in the urine or was it identified in the routine urine test? If it is a gross hematuria, ask for the quality. Is it a frank blood or there is a presence of clot? Associated symptoms. If the pain is present, ask for the location and severity of the pain. Is the pain referred to any locations? Is the pain continuous or intermittent? Are there any aggravating factors because of which the pain increases? Ask for the urinary symptoms like dysuria, increased frequency, urgency, change in the stream like has the stream become weak or dribbling. Always rule out any other cause of bleeding like has the patient started any vigorous exercise recently or their diet includes any food dyes or beetroot or any other. Red flags of hematuria. Always ask for these questions in your history to rule out high-risk causes of hematuria. History of smoking or occupational exposure to chemicals or dyes for bladder cancer. History of pelvic irradiation. History of chronic and recurrent urinary tract infection which might cause urethral stricture. Persistent irritative voiding symptoms in case of male draws our attention towards benign prostatic hyperplasia or prostatic cancer. Exposure to cyclophosphamide which can cause bladder cancer. In past medical history, ask for recurrent urinary tract infection, malignancy, hypertension, urological or nephrological disorder, and urinary retention. Past surgical history. Always ask for any recent instrumentations in the GU tract like cystoscopy or catheterization which might cause mechanical injury to the soft tissues of the GU tract and can cause bleeding. In case of female, always ask for the last menstrual period date to rule out pseudohematuria which might present as hematuria. Medication history. Always ask the patient for the current medications like anticoagulants which can cause bleeding, some drugs like NSAIDs, aspirin which affect the kidney and can cause drug-induced nephritis which present as hematuria. Family history. Always ask for the family history to rule out heritable disease causing hematuria like hereditary nephritis, polycystic kidney disease, sickle cell disease, malignancy, and renal stone. Social history. Certain habits and lifestyle can draw our attention towards diagnosis, like if the patient is of African American descent, which is the high risk group for sickle cell trait. If the patient has a history of smoking, it can cause bladder carcinoma. By knowing the occupation of the patient, like if the patient is working in some factory where carcinogenic dyes like benzene and aromatic amines are used, their long exposure can cause bladder carcinoma. Physical examination. In physical examination, first start with the general approach by taking vitals. Take blood pressure, heart rate, respiratory rate, temperature, and SpO2. Look at the appearance of the patient. Are they alert or lethargic? If they are lethargic with higher body temperature, think for sepsis. Look for the body build of the patient for cachexia, which is a sign of a malignancy. Also look for rashes, bruising, and sign of trauma. GI and GU examination. Inspection. Inspect the abdomen for swelling, scar, mass, sign of trauma, and bruising. Palpation. Start with superficial palpation and then deep palpation. Palpate mainly the right, left, abdomen, flank, and suprapubic region. Look at the patient's face while palpation for any sign of tenderness. Palpate the right and left kidneys. In case of female, look for the external genitalias, and in male, do the digital rectal examination as the prostatic causes like BPH and prostatic carcinoma are very common cause of hematuria in male. Auscultation. Auscultate for the renal broods. Investigations. Blood investigations include CBC, urea, creatinine, PTT, INR. Urine test. Start with urine dipstick test. In order to confirm the above finding, or if the above findings are negative, consider urine microscopy. Quantification of proteinuria, which is done by 24-hour urine protein test or spot urine protein is to creatinine ratio. Urine CS to rule out infection. urine cytodiagnostics to see the presence of exfoliated cells in case of transitional cell carcinoma of bladder. Imagining CT scan is the gold standard method, but in case of pregnant women and pediatric patient, in order to have less exposure of radiation, use ultrasound, or in patients who are contraindicated to contrast use in CT scan. In case of low risk patients, start with X-ray. If no conclusions can be drawn from above test, or to confirm the findings of the above test, some special tests are done like cystoscopy and renal biopsy. Treatment. Treatment of hematuria is according to the underlying cause. Some common cause and their treatment protocol are discussed here. Renal stone. Analgesic and alpha blocker like tamsulosin are the medication to start with. If the stone is less than 5 mm, it will get washed out on its own. But if the renal stone is bigger in size, or if it does not get washed out by the medication, use lithotripsy by shockwave or laser method, or do surgery as the last resort. Sexually transmitted infection. By swab or urine culture, identify the organism and its sensitivity and treat by antibiotics. Benign prostatic hyperplasia. Alpha-adrenergic antagonists like tamsulosin and 5-alpha reductase inhibitors like finasteride. If the symptoms are severe, do transurethral resection of prostate. Cystitis. By the urine culture, identify the organism and its sensitivity and treat by the appropriate antibiotics. IgA nephropathy. Start the treatment with blood pressure control with AC inhibitors or ARB. If they are steroid sensitive, treat with glucocorticosteroids or by immunosuppressive therapy. If no cause of hematuria is identified, that is, it is an idiopathic hematuria, follow up with routine urinalysis and urine cytology, or sometimes ultrasound or cystoscopy may also be required. Thank you everyone for watching this video. I hope this information was useful to you.